Welcome back. We are going to highlight some of the artwork. If you haven't noticed, the background that we're using, this big fancy electronic screen, is displaying different artwork day by day to highlight some of the topics that we're covering. Those of you in the sickle cell world will recognize Hurst Nazir's art behind us today. The late Hurst Nazir was a patient who really helped popularize some of the plight of warriors with sickle cell disease. And the most famous of his artwork, to my knowledge, is 10 Redefined, where he talks about how the scale of 0 to 10 does not express the emotion, the passion, and the reality of pain in patients with sickle cell disease. So Hurst's artwork is behind us. We appreciate the ability to use it. And Hurst died within the last year. So we just wanted to give him just due and let you know to pay attention to the artwork we're projecting up. All right, we're going to talk about COVID-19 today. In order to get it launched, we're going to do 2 polling questions. To respond to the polls, use pollev.com/VCU-HealthCME, all one word, pollev.com/VCU-HealthCME, all one word, or text VCU-HealthCME to 22333 to answer the polls. Let's look at the first polling question. True or false? The COVID vaccine contains live virus. True or false? All right, looks like most of you have answered, and it's hovering around 95% saying false. We'll cover that in the material coming. Next question. Once you get COVID, you cannot get it again. True or false? Once you get COVID, you cannot get it again. True or false? Some of you are responding in the chat. What we want you to do is to put it in the poll everywhere. The directions to poll everywhere are at the top. Okay, looks like about 97% of you are saying false, and we will cover that during the talk as well. Okay, now let me preface what I'm about to say. This is not, and I repeat, not a complete rundown, explanation, scientific exposition of COVID-19. What I am trying to do is to help equip you to how to deal with COVID-19 as a patient or an advocate with sickle cell disease, or of a patient advocating for patients with sickle cell disease. So I cannot cover a lot of the things that you might want to hear. For that, you have plenty of other materials to go to, the CDC website, the NIH website, and so forth. There may be some materials in your packet that you might want to look at as well. Okay. What is COVID? Well, COVID is a severe acute respiratory syndrome. It's a coronavirus. The technical name is SARS-CoV-2. It was identified in China And then in December of 2019, it was identified, and then since has globally spread. Most of us know that. There are several variants, and I will go out on a limb and say there will be several more variants of SARS-CoV-2. And you have learned them because they have been household names. The latest variant, I call it Deltacron. So we've been through, so the first variant, then we had the Delta variant, then we had the Omicron variant, and now there's a fourth variant. I'm calling it Deltacron. That's my little new term. And you can see the COVID cases. On the left-hand side, you can see the number of cases as amassed by the Centers for Disease Control, and on the right-hand side, you can see the number of deaths in the United States as amassed by the CDC. And the thing that should stand out to you is that it is going up and down. Now I ask you, what other infectious disease that you know about do the cases and the deaths go up and down? Don't all say it at once. It's the flu. So what we're thinking about is not something which will go away the way we hoped after coming on one time. This is probably going to be something like the flu. And as a result, that means that you can get it more than one time, just like you can get the flu more than one time. Immunity to the Delta variant does not guarantee immunity to the Omicron variant, or to the any new variant coming along. So that's a problem, right? Because that means you have to be on the lookout for this. It's another little pesky infection that we'll all just have to get used to. And I think we are having trouble accepting the fact that COVID is likely to be with us into the future. Life cannot go back to being pre-COVID. On the other hand, have we gotten used to the flu well enough that we can live our lives? I would say we have. We live our lives despite the flu being present. And I hope that we will get to the place where we can live our lives despite COVID being present. Now, how has COVID affected patients with sickle cell disease? Here's the good news. It hasn't been that bad. 973 reported cases in the secure SCD database as of January 22. Most of them lived. Very few have passed away. 19 deaths reported in this database as of January 22, 2022. At the beginning, we were very, very afraid. We are still very, very afraid. Why is that? Because sickle cell disease, as you all know, is a disease of reduced immunity. Remember, the spleen does not work, and you are susceptible to all kinds of bacterial organisms from 6 months on until adulthood. And remember, we talked about prophylactic penicillin being a prevention that kept people from dying as children. Overwhelming infection from penicillin sensitive organisms like the pneumococcus, the meningococcus, and so forth. Now, without getting into a lot of biology, let me just say the type of immunity that sickle cell disease seems to affect, while important and while setting you up for being susceptible to COVID, it does not appear to be directly making you more susceptible to death from COVID. You could still catch it, but apparently your immune system as a sickle cell patient works well enough that you don't die from it. Hallelujah. That'd just be one more thing we'd have to watch out for. So I'm glad this 19 is not 190. And I'm glad that we are not showing you that we're losing patients dropping like flies from COVID. We thought we were going to be. I'll be honest with you. We thought, and sickle cell disease is listed appropriately so as a risk factor for COVID-19 infection. That is appropriate because these patients are at risk for more infections. But despite all of that, we're doing quite well. In the top left, you can see in the orange, most patients have mild infections. In the top right, you can see that most people resolve their symptoms. And as I said, most patients do not die. Just in case you missed it, having it one time does not protect you from having it a second time. So a person who was infected and recovered may later become infected again. And we're learning more about these reinfections as we get these new types of variants coming out, like the latest one, the so-called B2, or I call it Deltacron. So viruses like the flu are constantly changing, and the COVID virus is a changing virus, and those changes lead to new strains, and those new strains make it easier to get infected again or reinfection. Now, why is COVID so infectious? It's infectious because it can be spread both by respiratory and by surface transmission. We're wearing masks because you can spread the COVID virus via respiratory methods. We are wiping surfaces and washing our hands and doing fist pumps and elbow pumps because it can be transmitted by touch from person to person. Now, you math fiends, on the right-hand side is a measure of infectivity. It's called the R0. Put simply, every infected person, according to this diagram here, affects 2 to 3 people before they recover from the infection or die themselves. So if you get infection and all other things are not there to protect, you can infect 3 other people before you recover or you die. Well, what if those 3 people infect 3 other people? That means 9 people are affected. Well, what if those 9 people each affect 3 other people? Now 27 people are affected. Well, what if those 27 people each infect 3 other people? You can see how the math lines up. And you're only about 10 to 12 generations down before 14,348,907 people have been infected with COVID. So if you're wondering why COVID spread the way it did, it was not some giant communist plot. It was simply people infecting people and not knowing it. And yes, it came from China to the United States and all over the world, but it was probably less a problem of purposeful infection and more a problem of it happened that way. So whether people wear masks, how sick the patient's already doing before catching COVID varies the R0, and how close people are standing to each other varies the R0, but in general, the R0 was 2.2. Each variant, by the way, is associated with a different infectivity. So this latest one, the Deltacron, is even more infective. The R0 is even smaller, or I guess that would be higher. COVID is exposing what we talked about yesterday. It's exposing healthcare inequities. It's exposing the fact that doctors and hospitals are overcrowded. It's exposing the fact that care is not equally available. We talked about the lights being on versus being off in different parts of the city. Similarly, COVID resources have been mal-distributed. People of color, undocumented immigrants, prisoners, factory workers have not benefited as much from rapid distribution of COVID preventive or COVID treatments than people in better equipped, better well-heeled populations. And the poor healthcare workers are overwhelmed. There's a real problem now with COVID burnout. You think you've got COVID burnout from being at home for 2 years and Zooming? Look at that tired nurse bent over her computer. That's a COVID burnout person. And they've got mask rashes, they've got hair probably falling out from wearing a hairnet all the time. They don't have to get to see their family. And healthcare workers themselves come down with COVID from being around it. So it's been a real strain on the system. I'm not telling you something you don't already know, but I'm just asking you to have a little pity when you come to see us in the hospital and in the emergency department, and it's overwhelmed with people. Half of them probably are worried they have COVID, want to get tested for COVID, and they don't care that you have a sickle cell crisis. Now, what does COVID look like? Well, if you get COVID pneumonia, which is probably the most common syndrome associated with COVID, by far not the only syndrome associated with COVID, it kind of looks like what we talked about yesterday, the acute chest syndrome. So on the left-hand side, you see the x-ray of a patient with acute chest syndrome. And on the right side, you see the x-ray of a non-sickle cell patient with COVID-19. And if you're not a radiologist, I'll forgive you for not recognizing that those look very similar, but we call that a reticular pattern. And we say that is usually a viral pneumonia or something other than a bacterial pneumonia that causes it. So both of these can occur at the same time in a patient with sickle cell disease. If you get sick enough, both of them can cause you to have to be intubated and go to the intensive care unit. My best buddy died from COVID pneumonia about 6 months ago. He had diabetes. He was 74 years of age, and he had been in the hospital for a diabetic coma 2 weeks prior to contracting COVID and came back to the hospital and died. COVID, as we have already suspected, is a racial disparities disease. It exposes our racial disparities. You can see cities like in Chicago, Louisiana, Michigan, New York City, where the rates are higher, the death rates are higher, and just like the lights were out and on depending on which side of the tracks you live on, the death rates are high versus not high in COVID for racial minorities. Blood. Now, this is huge. Because of COVID, people have been afraid to come out and donate blood. It has majorly diminished and still continues to diminish the blood supply. Well, that's important for patients with sickle cell disease. Many patients with sickle cell disease depend on transfusions, as you learned yesterday, some of them for life. And the availability of transfusions has been severely restricted depending on which part of the country you live in. And the American Red Cross is out urging people to donate. I urge you to donate. If you are an eligible blood donor, I urge you to donate to your nearest American Red Cross. There is continuing to be a critical need for blood because of the coronavirus outbreak. And sickle cell patients suffer because of this. Back to the question, when will COVID end? I'm going to say the short answer is it won't really end. We're going to have to live with it. But here's 4 definitions of the end of COVID. The public health end of COVID is kind of coming now, isn't it? None of us are wearing masks today. We are not tracing contacts the way we used to. The numbers of people with the virus are going down. So you could say the public health end of COVID is either here or rapidly on its way. When will it end medically? Well, maybe we'll get some drugs, maybe a pill or a shot or other broadly available intervention that can treat COVID the way we found drugs to treat HIV. Or maybe it will sort of burn itself out. At some point, instead of the infection rates going up, the infection rates will go down so much that the virus will be contained, and you could say it sort of burned itself out. It won't be completely gone, but it will have burned itself out. Socially, it will end when we decide to end it. And now we're getting into the politics, are we not? Some people decided it never started. And some people decided that it ended, 6 months ago, and they said, I'm done with wearing masks. I'm going to live my life. I'm getting back on airplanes. I'm traveling. I'm having a party. I'm going to spring break, etc. And we stopped paying attention to it. I don't think we've stopped paying attention yet. I think it's still with us socially. But there are people who can afford to ignore it who are doing so. And then finally, the political end. When government support and attention and involvement ends and we have a war in Ukraine or we have something else that takes the headlines, and then suddenly COVID is no longer in our frontal lobe. So that's my interpretation and this columnist's interpretation of when we will see the end of COVID. Okay, so Smith says COVID is going to be with us. It'll never end. What are we going to have to do about this? Well, let's start with some easy things. Folks, get vaccinated. Please, get vaccinated. Unless you're against all vaccines, in which case, okay, you decided you never want to have a vaccine. You don't want to ever have a smallpox vaccine. You don't ever want to have any vaccines to get you ready, your kids ready to go to school, and you are religiously objecting to all vaccines. All right, I can live with that. But to just pick on COVID and say, I'm not taking that vaccine, I don't think you got a leg to stand on. Look at who developed the Moderna vaccine. She doesn't look like somebody with an agenda to end the lives of black folk. That's Kizzy Corbett. And Kizzy Corbett helped develop the Moderna vaccine. And Kizzy Corbett is out on the speaker circuit trying to get people to get vaccinated. 46% of blacks decided not to get vaccinated versus 30% of whites. They're worried about the side effects. There are side effects. They say the vaccine was developed too fast. That's half true. They worry about the legacy of exploitation. Tuskegee did happen. Exploitation does happen. All of those are sort of true. But let me see if I can talk you into understanding that despite all of those things, it's still safe. Okay, the technology is new, and people worry that we're being experimented upon, and that's not quite right. The technology has been around, but it has not been widely disseminated, and people hadn't known about the technology. So when it was applied by Kizzy and others to develop the COVID vaccine, it did not take as long to develop as it might have otherwise. People are worried about DNA and fertility. Similarly, the way that they were worried about getting HIV from the gene therapy that we talked about yesterday, gene addition therapy. And then people look at their social media and believe everything they see on social media, which has its own problems. There are some valid religious objections to the vaccine. Let me walk through that. The non-replicating viral vaccine produced by Johnson & Johnson used fetal cell cultures, specifically per.C6, in order to produce and manufacture the vaccine. The Pfizer and the Moderna vaccines do not require the use of any fetal cell cultures in order to manufacture those vaccines. And the vaccines themselves, and here's the distortion, it's out there that the vaccines contain aborted fetal cells. That's just wrong. That's just not right. Now, here's another point. If you don't want to use the Johnson & Johnson vaccine, then you also do not want to get a chickenpox vaccine, a rubella vaccine, a hepatitis A vaccine, a rabies vaccine, all of which utilized fetal cell lines in their development. You can read about this at the link that I show you at the bottom. I am an evangelical Christian. I understand this objection, but it's sort of like this. The vaccine has now been produced. I can't go back and unproduce the vaccine, and it is doing good. So I'm going to take advantage of a product that is doing good. Would I have tried to get people to not use fetal cell lines? Okay, that's a separate issue. Not an issue today. That's history. Now we have these vaccines, let's use them. All right, here's another fear. They're manipulating my DNA. Not exactly. They're taking messenger RNA, and Dr. Lopato talked about this yesterday. They're taking messenger RNA that codes for part of the virus called the spike protein, and they're injecting that into you. That messenger RNA turns your body on to produce the spike protein. And the spike protein is the part that fights the virus. So we are tricking your body into producing immunity against the virus. We are not changing your DNA, that is coding for what happens to your babies. We are changing your ability to produce protection against the virus. Is it dangerous? Are people dying from COVID vaccinations? Well, every time somebody does, it's on TV. And yes, a couple of people have died from COVID vaccination. But what's the chance of that? You have more chance of dying from a lightning strike than you do from a COVID vaccination, and you have more chance of dying from COVID than you do from a COVID vaccination. Pick your poison. Would you rather take a chance at getting a lightning strike, getting COVID, or not? I hope you decide not. So, I think I might have said this before, get vaccinated. Either way, if you don't want COVID, don't go out. The best way to not get it is to not be exposed to anybody who has it. And in fact, if you don't go out, you can't let your family go out. I don't think we can live that way forever. But what you might want to do is stay home unless absolutely necessary. Certainly follow your region's recommendations for voluntary or mandatory masking, and that is sort of going away because people are loosening up on masking. We can't go on forever doing it and live practically. Wash your hands. That's something you can do all the time. 20 seconds or more, sing, what is it that we sing? Are you sleeping, Brother John? One of those. And 20 seconds will go by, and then you know you've spent enough time washing your hands. Or use a hand sanitizer with at least 60% alcohol. Avoid touching your eyes, nose, mouth, and face. This sounds like flu vaccination and flu prevention guidelines. Avoid being close to people who are sick, coughing, or sneezing. Disinfect, frequently touch objects. Cover your mouth when you sneeze, cough. Very, very practical ways to prevent COVID. All right, what do you do if you get sick? The first thing you think about is running out and getting somebody to look at you, the doctor. And that's why the emergency departments are full of people with COVID fear. They may have COVID, they may not, but they have COVID fear. A little bit of a fever, a little bit of a cough. They want an x-ray to be absolutely sure that it's not COVID. And that just backs the system up. We don't recommend doing that. We do not recommend doing that. What you could do is call somebody, your doctor, preferably, and see what they recommend to do, especially if you have a fever. We use fever to differentiate a lot of times the sick from the non-sick COVID patients. So get a thermometer. If you don't have one, go out and get one. Don't just feel your head and say, I feel hot. Get a thermometer. And if you have a fever, don't assume that it's COVID. It could be the flu. It could be a cold. It could be something else. And then call somebody and ask, what do you think I should do? I've got sickle cell disease. I'm worried I might have COVID, and get advice about what to do. They're going to ask you a bunch of other symptoms. We have a list. We asked 600 of our sickle cell patients about 2 years ago. We called them and asked them, have you had COVID symptoms? We were so worried that our patients were going to be dropping dead like flies. And again, we were very gratified and relieved to see that patients were not dropping dead like flies. What do I do about the blood supply? Well, first of all, talk it over with your doctor. At VCU, we have gone up and down with, yes, you may come in for a transfusion, we have enough available blood, and no, I'm afraid we will have to wait another month or 2 extra weeks to transfuse you because we simply don't have enough blood. And our blood bank, bless their hearts, they are very, very sensitive to the fact that these are life-saving treatments that they are withholding from patients. And they have worked with us to, as best as possible, not withhold blood from needy sickle cell patients. But there are some places that can't help it. Can I get infected from blood? And basically the answer is probably not. We are still looking at that, but at this point, we don't believe that there is a major chance of your getting COVID from the blood supply. I think I covered this already. If you are sick, try not to go to the emergency department. If you need to go somewhere, you might go to a place that you can get tested for COVID. Drugstores do it now, as you all know. The urgent care centers can do it. There's lots of places you can go now to get tested. There's even home COVID testing available now. So I would say if you have no other option, go to the emergency department, but do what you can to not go. Okay, so I think you have heard me say loud and clear that COVID is probably with us, and it's probably gonna still be with us a year, 5, 10, 100 years from now. The flu pandemic, for those who are not aware, the flu pandemic was in 1918. Something like what is happening now with COVID happened with the flu in 1918, 100 years ago. And we're still talking about the flu, although it's not killing people the way it used to. We're all at risk of getting infected. People with immune systems that are weak, like sickle cell patients, should consider themselves at risk, but don't be too fearful, because at this point, it has not killed a lot of sickle cell patients. Prevent serious infections, get vaccinated, stay safe, do the best you can to keep yourself and your loved ones safe. If you want more information about this, here are some trusted websites. Our own Sickle Cell RVA, the Sickle Cell Disease Association of America, other CBOs, and then the CDC, the Centers for Disease Control. These are good places that you can get information about the COVID. All right, we have some questions, and I'm going to read the questions out and then try and answer those questions. You can continue to put questions in, and we will answer them. The first question: how is the data entered into the secure sickle cell disease database, and who's entering it, who's sending it in? Is it collected from every hospital in the United States? It is voluntarily entered by whomever wishes to enter a case. Now that means by definition that we have missed a lot of patients who have had COVID-19 and sickle cell disease. But we have encouraged from the get-go centers to enter every case in of their knowledge. And here at VCU, we do that. Every time somebody with sickle cell disease, that we become aware that somebody with sickle cell disease has COVID, we put that case in. There is no way to catch every single patient in a census-like fashion and enter the data. Where did the fetal cells come from? Okay, so this goes back to how the virus was developed. From the get-go, virus development has been tested on fetal cells. The fetal cells come from aborted fetuses when someone has an abortion. So the religious objection there is, if you are against abortion, then you don't want anybody using cells from aborted fetuses to test anything. But I go back to the place that viral testing went on for decades before people recognized it, and I named a bunch of vaccines that have been developed that way, not just the COVID vaccine. Can you address the new recommendation about getting a second booster shot? Not only can I not address it, I cannot address half of the problems and issues with COVID that are coming up on a day-by-day basis. We didn't even talk about the first booster shot. So I can say that we have now booster one, two shots to be fully immunized against COVID. Booster shot required for some employees, like VCU. And now as new variants come, second booster shot being suggested for those who are more severely ill. The guidelines on that are still being formulated. So I will just simply say that as COVID evolves and as variants of COVID continue to appear, just like you have to get a flu shot every year, I fully expect that there will be some recommendation about getting a COVID shot every year. I know you didn't want to hear that, but I think that's where we're headed. Again, it's sort of like the flu. And so that's where we're probably going to end up. But I cannot tell you today, yes, you better go get that second booster shot, because I don't think the data are good enough to say, and the CDC is still formulating recommendations. about the second booster shot. Okay, it looks like there may not be any further questions about COVID. Are we breaking or are we continuing? We're continuing. Okay, we're continuing now, and we're leaving COVID, and we're going to sort of pick up where we left off yesterday. So where we left off yesterday was that racism is real, health disparities are real, and it's real in sickle cell disease, and we need to do something about it. We didn't tell you much about what we're doing about it. I think I put up a single slide with recommendations for dealing with racism and health inequities in sickle cell disease. Today we're going to dive in, and Joan Quarter-Mabe and I are going to hit you all over the head with the U.S. and even world recommendations for public policy and public health measures to deal with sickle cell disease. And there are some real recommendations. So with that, we'll get started. All right, I got a polling question for you. Remember how to address how to get to the polling questions? It's pollev.com/VCU Health CME, or text VCU Health CME to 22333. And then once you join, put your answer in. This is going to be an A, B, C, or D answer. Question: the number of living sickle cell adults versus children in the United States is A, 2 to 1. That is, 2/3 of people are adults. B, 1 to 1. Half of people living with sickle cell disease in the U.S. are adults. C, 1 to 2. 1/3 of people living in the U.S. with sickle cell disease are adults. D, 1 to 3. 1/4 of people with sickle cell disease are adults. So is it 1/4 who are adults, 1/3 who are adults, 1/2 who are adults, or 2/3 who are adults? A, B, C, or D? Great. We will come back and we will nail that question. I'm not going to answer it. I'm going to keep you in suspense. There's another polling question. The U.S. blueprint for sickle cell disease, A, was written by the Sickle Cell Disease Association of America. B, failed to include racism as a cause of poor sickle cell care. C, outlined 4 structural models for adult sickle cell centers. D, strongly supports funding community-based organizations and other non-medical supports for sickle cell disease. This is great. This is why we do this course, Joan. All right, let's keep going. All right, so, and I'm going to wander around, so get ready to follow me. So the ideal care for a person with sickle cell disease is to not simply get them through childhood. We've shown you that getting people through childhood and into adulthood does not keep them alive in adulthood. We've shown you that the bridge across the care chasm from childhood care to adult care is over a deep, rocky river of death. We've shown you that the bridge is rickety, that the systems of care that exist in peds don't exist in adult care. We're going to nail that again and talk about that again today, and talk about that bridge, and talk about what we can do to strengthen the bridge so that the handoff from the pediatric to the adult system is stronger, and so that the care on the other side of the bridge is better. The ideal for that care would be a medical home. A medical home would be led by a sickle cell specialist. It would include primary care and specialty care. This is what the pediatricians have. The community services would be integrated. There would be value-based payment. That is, for every patient you keep out of the hospital, you actually get more money pumped into the system, not less. This is what we got. This is the reality. The adult side of that bridge looks kind of like this shack. And I live in it. We adult providers live in a shack like this. Sometimes physically our facilities are not good compared to the pediatric facilities. Our systems of care are broken. Okay, here's the answer to one of those quiz questions. It's not 1/3, it's 2/3 of patients with sickle cell disease who are adults. And therein lies the problem. We don't have a system of care for 2/3 of our sickle cell patients now. 30% of our sickle cell patients are on the bridge. That rickety bridge that I just got through talking about. And they're dying. They're getting hospitalized more. They are sicker because as children, their disease was sort of under control, and then they move out and they stop taking their medicines the way they're supposed to, and life hits them in the face, and a little alcohol and a little drugs and a little sex and a little this and a little that. And between the ages of 18 and 30, we are losing our patients. So the paradox is that the lifespan of sickle cell patients as a whole is going down, not up. And it's not going down because of terrible pediatric care. That continues to be good. We got rid of the hump that was associated with mortality in the pediatric years. And that hump was due to infection, so we got penicillin, and it was due to strokes, and we've got transfusion, and we were working on acute chest syndrome. But when they get on the bridge, it sometimes collapses, and they fall into the alligators. Or they get across the bridge on the other side, and it's a wasteland. And they look at the shack, and they decide, I want to go back. I get that a lot. Dr. Smith, I like you, but can I go back to my pediatrician, please? Things were nice over there. The walls were pretty, and they had Xboxes, and it was great. And your emergency room stinks. It's full of all those COVID patients. So we've got a problem. 2/3 of our patients are adults. 1/3 are transition age. Those are the people dying. Those are the people going to the hospital. Well, what do we need to get rid of the problem? To treat these complicated, complex, chronically ill now patients, many of whom are getting chronic pain. Well, let's look at another disease to ask that question. What does cystic fibrosis have? Well, it has all of the same problems of sickle cell. And so to improve the quality of care for cystic fibrosis patients, what have we done? We have longitudinal clinic data collection. We have a registry. We have coordinated care targeting improvements. We have funding for quality improvement. We have funding for therapeutic development. We don't ask cystic fibrosis patients to get their care from a generalist. We send them to a specialist. Nobody would dare say a cystic fibrosis patient needs to go to a general pediatrician or a general internist. No, they need a specialist. We don't ask hemophilia patients to do that. We have coordinated systems of care. Why should we ask sickle cell patients to do that? And as I told you yesterday, 30,000 patients with cystic fibrosis, 100,000 patients with sickle cell disease. And in fact, if you combined hemophilia and cystic fibrosis, you still wouldn't have the number of patients we have with sickle cell disease. And yet, the bridge is collapsing. We live in a shack, and it's a wasteland. Let me go back. I love that shack picture. That is just, it says it all. What are we going to do about that shack, folks? And that's what we're going to talk about today. What are our public health issues with getting this shack turned into a gleaming, it doesn't even have to be a skyscraper, it could just be a nice little office building with some parking places. I think I went over this yesterday, 75 times more funding for cystic fibrosis. All right, so if you haven't figured it out, sickle cell disease is bad. I think I've covered this in great detail. I'll keep going. And I think we covered this yesterday too. And I said this, so we're sort of at step one. We're at base camp one with fixing the problem. Now, I wanted to emphasize that we were pre-base camp one until about 4 to 5 years ago. So I want to give credit where credit is due. Improvements have been made in our public health approach to sickle cell disease. Shout out to the CDC. Shout out to the Health Resources and Services Administration. Shout out to the National Institutes of Health. Shout out to the adult centers that have stepped up and put together centers. Shout out to the American Society for Hematology. I am not ignoring that. Shout out to industry for the drugs that have been developed. I'm not ignoring that. But we're still at base camp one. We do not have a system of care for adults with sickle cell disease yet. Enter the US government to say that from the bully pulpit of the National Academy of Sciences, Engineering, and Medicine. So we have a national authority saying out loud that improving health outcomes from sickle cell disease is a public health crisis. And that payment models, and yes, racism, that's your second question, racism are a part of the issue in improving care for patients with sickle cell disease. This report was released in September of 2020. It was landmark. Several authorities from around the country helped put it together. It is 522 pages. It has multiple recommendations. It calls out every agency within the Department of Health and Human Services. The Secretary of Health and Human Services himself feels called out by the report. We have met with the Secretary of Health and Human Services to address issues brought up by the report and what he can do. So he knows he's been charged with helping to execute parts of the recommendations in this report. Here's a recommendation. Disability insurance qualifications. We haven't done anything about that yet. Patients are losing their jobs, not getting jobs. We have to write work excuses and claim that people have had a crisis when the work will not believe that they've had a crisis. Why? Because they didn't go to the hospital. Well, guess what? 3 out of 4 days spent in a crisis are spent at home. People don't like going to the hospital for a crisis. Vocational rehabilitation. Cognitive deficits, we discussed that yesterday. Silent ischemia makes the brain not work so well. People try and cover it up, but their brains don't just work the way they're supposed to. They need vocational rehab so they can get neuropsychological testing, so they can get the right job, so that they don't get fired all the time. There have been some activities to delineate the elements of a comprehensive system of care, including community supports, that's where you guys come in, to improve health outcomes and health inequities. There's been activity there, thank goodness. We're going to talk about that. How well do we feel we're doing with the ability to erect an office building out of a shack? Are we able to evolve from episodic and longitudinal care in an outpatient, in an emergency department, to care in an outpatient setting? Maybe. People answering this survey, 80 of them, said, okay, yeah, 3/4 of them said, yeah, feel like I can probably do that. What about leadership change? What about management change? Starting to get slim, only half. What about community engagement? Also slim, only half felt confident. What about advocacy and alliance development? Alliance, what's that? What about a business plan so that the people who are going to pay for the office building feel like they're going to get a return on their investment? Pitiful. 35% felt confident they could put a business plan together. You can be sure the cystic fibrosis and the hemophilia plans are well put together. The hemophilia plan often is a cash cow for the hospital. The money that it pays for a factor to treat the hemophilia is actually paying for care. Would that we had that ability. I'm very proud to show you this diagram. Julie Cantor, myself, Payal Desai, Marsha Treadwell, and many other leaders around the country put together the Bible for how to erect an adult sickle cell program, and we published it in 2020. We outlined 4 classic models for what your office building could look like. You could have a classic comprehensive sickle cell center. Now, what's that? Well, that's basically what the pediatricians have. Or an embedded sickle cell center. Well, that's kind of basically what the sickle cell centers look like in pediatrics as well. So embedded is within a cancer center, okay? So you just take what the cancer center has and you use those resources to take care of sickle cell patients. A classic comprehensive would be, I've got so many patients, I can have a separate unit from the cancer center. And then you can have a specialized medical home. That's what we say we have at VCU. It is a specialized center, but it's got primary care and care coordination and all sorts of people like community health workers, and it's got community-based organizations integrated into the care. We aspire to be a specialized sickle cell medical home. Or, depending on where you live, you could have a hub and spoke model. Let's suppose there are rural sickle cell programs that only have a few patients and 1 or 2 champions that want to hook up with a more central and urban sickle cell program with a lot of patients, the ability to accept referrals, and the ability to communicate with patients who come back and forth between the hub and the spoke. You could have that. Some of you have already developed 1 or more of these models. And I encourage you to look at this article, decide which of them you are, and work on developing your center. And I'll put a plug in right now for the American Society for Hematology. Every year, we invite 10 to 15 new adult sickle cell programs to apply for a 4-day conference, not unlike this one. It's in DC. We bring you up, we bring your entire team up, and we teach you nuts and bolts of how to erect and maintain an adult sickle cell center. So the ASH Sickle Cell Disease workshop is coming up, actually, in about a month, our third or fourth one, just like about our third or fourth SCCAPE. So please apply. You can go to the ASH website, and you can see how to apply. What should be in the center no matter what? What is the essential? Now, this is a little controversial because a lot of people think infusion has got to be central. It does not. You do not have to have an infusion program to have a sickle cell center. The required elements, the minimal components, reflect resources that are valuable, and no matter what your model is, you got to have that. Central to it is a champion. You got to have a champion. Does it have to be a doctor? It helps. Could it be a nurse practitioner or a physician's assistant? Yes. Yes. Do they need to know how to care for sickle cell disease? Yes. If you really want to have and call yourself a sickle cell center, the champion needs to know how to care for sickle cell disease. Well, what if they just have the passion to learn how to care for sickle cell disease, but not yet know how? Go get some training. Again, ASH has some training options available. You do not have to have a fellowship in hematology oncology. That is optimal, but that is not required. You do have to have some knowledge of major complications of sickle cell disease, how to manage those complications, and how to direct others to manage those complications. That's the chief reason why the champion needs to have some knowledge of sickle cell disease. So when I say champion, I really mean medical champion. A business champion, while not essential, is also optimal and definitely going to move things along. So the best team, in my experience, is you have a medical champion alongside a business champion. Now, the business champion could be a hospital administrator, could be a CBO person who understands business very well, could be another member of the healthcare team who understands utilization and quality improvement and can write a business plan. But those are essential elements. Other essential elements, something to deal with the social determinants of health, social workers, care coordinators, nurses. You got to have a pain management plan. You need to understand how to do transfusion. You need to have timely access to support services. We consider these things essential. And notice I didn't say infusion. Now, infusion made the next level, right? A day hospital or an infusion center is optimal. I'll let you in on a little secret. VCU's infusion center still isn't really running the way it needs to be. And we've had a program for 30 years. I'll say that again. Our infusion center is still not running the way it needs to be. And we've had a program for 30 years. And we've had an impactful program for 30 years. Now, it turns out that if you look at the history of the adult sickle cell programs that have the most time under their belt, we are an outlier. Emory, Montefiore, Hopkins, places like that, live on the infusion center as a central part of what they do. So I am not knocking infusion centers by any stretch of the imagination. But I don't want you to think that a sickle cell program is an infusion center. It's not. All right, other issues. Reimbursement models. Guidance for teachers, school nurses, school administrators, and primary care providers. As you can see, there's been activity in each of these areas. Legislation. There's been legislation submitted now to fund clinical sickle cell centers. We will see what Congress does. The state of Virginia, the state of California have all obtained funding to fund adult sickle cell centers. Our funding just went live about a month ago. Healthcare institutions are paying for these centers. And that is really the best place to go, is healthcare institutions to start your program. They've got to have skin in the game, else you're never going to have longevity to your program. So I highly recommend you make a business plan to your hospital or your healthcare institution or your county or your region. Quality improvement is central to evaluating and running these programs. If you want to continue to get money, you got to show results. We will show you our results a little bit later when Shirley gets up and talks. But here's some results from a nationwide program funded by the Patient-Centered Outcome Research Institute that involved 14 centers in 8 states. And we're showing improvements in quality for adult and pediatric clinics in transitions of care. That's what this was focused on, meeting quality indicators for transitions of care. And you can, the main point here is that the bars are getting better with time. Alliance? What is that? Well, here's one, the National Alliance of Sickle Cell Centers. Brand new organization, President Julie Cantor from UAB. First 2 years of organization. You can join, there's the website. When you join, we're gonna ask you to share data. We're gonna ask you to come to meetings, and we're gonna ask you to help get the organization up and going. It's still fledgling, and we need lots and lots of help. The National Alliance of Sickle Cell Centers. Pediatric and sickle cells and adult sickle cell centers may join. There's the website again, and there's a mission statement. Now, I would like to introduce my colleague. I almost called her doctor. Dr. Joan Quartermaine. She's sort of not earned her doctorate, but she's done enough to earn it, in my opinion. And Joan is a veteran of the Virginia Department of Health. She's a nurse practitioner by training and has been working in public health programs of all kinds for decades. She's not really retired, although she retired from the health department. She is one of the organizers of the SCCAPE program and the curriculum. And she's going to talk to you about community health workers in the U.S. healthcare system, and then we'll come up for some joint Q&A. Joan.
Well, good morning. I've been here and been enjoying all of this wonderful interaction, and hopefully you guys are doing the same. So it's nice to actually be up here and have a few words. I'm kind of the innards of a sandwich here. In listening to Dr. Smith, he really is moving us right into this topic, and then Shirley's going to come up and move right on further, and then the rest of the team. We're moving into the so what and what can we do. And being the public health person that's been involved in this project, I have to say, COVID really did show some major gaps in our public health system. And also, what has been happening in the last few years, public health funding since 2019 is actually, since 2010, has actually been reduced by over 10%. Our public health structure is under major threat. And in the last 2 years, our public health workforce, now get this, we're in the middle of a major pandemic, but the workforce has actually decreased by 21%. So therefore, that's a bit of a conundrum, is it not? So the whole idea of community health workers, even though it's not a new idea, is now beginning to take some real shape as to what's happening. So that's kind of why I'm here today, to just introduce this thought of using community health workers. We're going to get into it in much more detail tomorrow, but for right now, because as we move into talking about this medical care home and team, we wanted to make sure that we all kind of were on the same page as to what a community health worker is. So I am going to go through very quickly a little bit of the history, because this is not a new thought. Actually, and I'm going to say the word Russia, in 1800s actually had what we would now call community health workers. And in the 1920s, China had what were called the barefoot doctors. It was actually a grant from the Rockefeller Foundation that went and trained non-physicians to actually do things like record births, to talk about vaccinations. And in that time, smallpox, we had a vaccination, and they were out trying to get people to take it. Does that not sound familiar? And then in the 1960s, and I'm old enough, I remember this, is that the federal government actually got into this whole thing, because they looked at what was going on across the world and said, hey, we need to start promoting this. The Native American, the tribes actually picked up on this better than some of the rest of our country, and actually started working with the tribes that were supported by our government, and on the reservations had non-physician folks, of which the folks in those tribes actually dealt with better because of the culture. So then in the 70s and up into the 2000s, the American Public Health Association also actually officially got involved and actually supported the development. They established their own community health worker section and adopted a definition. And in 1998, there was a report, the National Community Health Advisor Study, which was a study from all over the country and actually looked at the competencies and the qualifications of what a community health worker should be. And in 2007, HRSA actually did a national workforce study and included 31 states, including the District of Columbia. They did major surveys, they interviewed people from all over the country and published the report. So why I say this, and also I know many of you are very aware, in 2003, the Institute of Medicine, which I think what is the Academy of Science, but they've changed their name, but at that time they were Institute of Medicine, put out, I'm sure you're all very familiar with what was called unequal treatment. That study, or that publication, actually called for community health workers to be part of the medical team to address, guess what, health disparities. So see, that was a good ways back, that even medicine was standing up and saying, hey, we need these people. We need these people. So more recently, 2010, the Bureau of Labor Statistics actually recognized community health workers in that particular part of the government, actually counts who's out there and jobs, and community health workers were actually mentioned in that. 2010, which to me seemed just like yesterday, but President Obama at the time signed the Patient Protection Affordable Care Act. We've heard a lot about that all these years. But in there, it also called for community health workers to be part of the medical care team. It seemed like to me we've got a little theme going on here. In 2013, actually our National Medicaid Office, the CMS, also allowed for reimbursement of community health workers. But guess what? Is that happening today? Not particularly, okay? A lot of other complications there because as many of you, if you've dealt with the government, you know, people question, is it, who are these people? What are they doing? Well, why is that? The doctors over here and the nurses over here, the social workers over here. Why do we need these people? So a lot of things. But as we move forward, and I mentioned that the Public Health Association came out with the definition of a community health worker. And it's pretty long, and it talks about the community health worker. I like the term frontline public health worker. I think that's an important concept. It's a special member of the team who is linking with the community. And I think that's where you alluded to, Dr. Smith, in that, we can have a wonderful medical care team made up of social workers and nurses and the doctors and the physician assistants and the nurse practitioners, but unless we can connect with that community, it's going to be all for naught. Just because you build it doesn't mean they're going to come. And we know that from what we've experienced the last 2 years with vaccinations. As the vaccination came out, we thought we were going to have this COVID under control completely, last summer? Didn't work, did it? So certainly helped, but it certainly didn't cure our problems. So what is a community health worker? Well, we're going to talk about this in much more detail tomorrow, but the reality is it's a lot of different titles out there, and many of you may be out there in the audience and going, well, we don't have any community health workers, but you know what? You may have an outreach worker. You may have a health coach, you may have a lay health advisor, you may have a community health advisor, you may have a patient navigator. There's a lot of different terms out there, and we really, as over the last few years, have realized that the community health worker is now the umbrella term of these folks that are not licensed clinical people. How are they different? Well, this is where we can get interested into some discussions. I've been very involved in the movement here in Virginia since way back in the 90s. And I'm going to say they because it's community health workers, will use the term unique, okay? Those of us that may be licensed clinical social workers or nurses go, well, wait a minute, what's unique? So that's a discussion that's still going on. But they certainly are people that do not provide the historical type of clinical care, okay? They are usually not licensed. They share, or the idea is that they share the culture and the environment of the population or the group that you're trying to work with. Community health workers up till now have been very involved in those folks with chronic diseases. HIV was one of the first that really became, but they were kind of mostly peers or people that were experiencing HIV. Community health workers have been very active in the world of diabetes care, breast and cervical cancer care, cancer in general, prostate cancer. So there's a lot of models out there that have been very involved in chronic disease, but not particularly in sickle cell disease until fairly recently. Community health workers focus on the social determinants of health. I hope you understand, or you're beginning to get the hint. We talked about social determinants of health yesterday on purpose. We wanted to talk about that. Dr. Smith has alluded to it again this morning, and we're going to be talking about that for the next 2.5 days. And that community health workers, one of their biggest areas is to focus on those social determinants of health care. We all know, I know from this team, one of the big issues may very well be transportation. And Dr. Smith, he's busy in his clinical area doing his thing and his research. He doesn't have time to be on the phone tracking down a Medicaid cab for Mrs. Jones to come into care, okay? But a community health worker, that's something they can do. So how are they different? We can talk about that, but they're doing things that traditionally are not part of traditional in-hospital care. Something that Dr. Smith actually said this, but he pulled it from somewhere else, I think. But if cost savings for community health workers were the results of a clinical trial for a drug, we would likely see pressure for fast tracking through the FDA. And that has really not happened, which is interesting because we know using community health workers can be very cost effective. Now, I'm going to give you a few examples here, and I'm going to run through these pretty fast. We know that community health workers can increase your patient outcomes. In the world of diabetes care, they actually, patients did a better job of monitoring their glucose levels and actually lost weight. A lot of examples of that. Increase access to care. Lots of good examples of how community health workers help people get into care, whether it was physically through transportation or even just knowing that they needed to go for care. The finance or enhancing quality of care. If you do patient satisfaction scales, what some of these projects did, patients were much more satisfied with their care. They felt cared for. Lower cost, linkages, all these good things that are out there in the literature, and I'll allude to more tomorrow, but in some of our studies, we published a paper with over 200, I think, and 30-some journal articles that we used actually demonstrating the effectiveness of community health workers. We know from our own personal study, or not my personal, but in the team, looking at emergency care and cost at emergency, how you can save ED visits in working with patients, whether it's diabetes care or heart disease care or sickle cell care, all right? We know that in the IOM study, they talked about, even though there may not be true random control studies, which we attempted to do one, but they're just not out there and looking at community health workers, does not indicate lack of causation or ineffectiveness, though. So the group of the Academy has come out and said, you know, we don't have to wait for for control studies to really know we need to use these folks. I'm going through. Maternal child is where I spent a lot of time in my career, and that's kind of how I got passionate about community health workers. We were able to make major progress. And remember, Dr. Royster talked about low birth weight. In low birth weight, the use of prenatal care, infant mortality. There's been a lot of good programs out there that have been focused on maternal child care. And we know that in other topics, as I mentioned before, in the control of heart disease, high blood pressure, patient knowledge, control of diabetes. I also had a lot of experience in working with community health workers in the breast and cervical cancer program out of the CDC, and that Virginia long-standing history of having a major grant, which that was one thing that I did and worked with. And we went, oh, we need to get our patients in for care, and guess who were not getting in for breast cancer screening and cervical cancer screening was our African Americans here in Virginia. We were doing a terrible job. And so guess what? We went and used we borrowed community health worker model from our resource mothers over maternal health. And guess what? Within a year, we made significant inroads on getting our African American patients in Virginia into care. Other states did the same thing. So we know it can work. Just a couple of policy, and I'm kind of up here at 30,000 feet, and as we move through the next day or so, and Shirley gets up here, we're going to hone down a little more, but just to give you kind of that global look as what are we doing in our country about the use of community health workers in practice. And in this photo, this is actually very difficult to keep up with this. I can tell you as a person who tries to do that. It changes every day, all day, and it takes time. And I have done some of this work personally, trying to keep our team somewhat educated on this movement. Most states, though, do not have laws concerning community health. Now, those of you that are doctors and nurses and social workers, you got all kinds of laws, don't we? We have regulations and laws and a license, and I just had to do mine the other day. Luckily, we can do it electronic, but it's saying, oh, have you done your continuing education? I went, oh gosh, I don't know, do I have enough? Well, luckily I participate in this project, and that helped. So language used is not consistent, just as I alluded to earlier. Across the states, there's so many different titles of what a community health worker is. Certification, oh my gosh, it's just no consistency across the nation. Virginia just did this in the last 3 years, and I was very much involved in all of that work, and it's not perfect by any means. Florida has done a lot of good work. Texas has done a lot of good work. Alaska, believe it or not, has done some good work. But overall, it's not like there's a certification that there's any standard whatsoever. There's no standards regarding training requirements. And so one of the precursors to the SCCAPE conference was actually our training curriculum that we used in our patient navigator program in sickle cell. And we still think we have a great product, but if you go out to the literature, there are some people hiring and putting community health workers in place, and they've had 4 hours of training, 4. There's others that have had 40 hours, 80 hours. It is very variable across the country. And being a person who's tried to keep up with this, actually spent time on the phone and on internet sites trying to figure out what the different states are doing. And it's quite variable. Medicaid payment now, a few years ago, only one state reimbursed for community health workers. That was Minnesota. And they actually connected their community health workers to their community college system. But since then, other states have moved forward. So there's like 15 states now that actually allow this reimbursement for community health worker time and effort. So there's constant change. And I'm sorry, I know our time. We're good? Okay. There was a major study out of University of Texas, did it on behalf of the, actually on behalf of HRSA that wanted it to get done. It was funded by the Robert Wood Johnson and the National AHEC organization and the MESA Public Health Association. And at University of Texas sent out a survey all over the country. We actually participated in that here in Virginia. I know because I'm one of the people that filled out the stuff. And then they published this report in 2019, or 2016, excuse me. And this has kind of become our Mecca project. And what they did was listed all the desired qualifications of a community health worker, what their expected skills should be, and what are their roles and responsibilities. We're going to talk about some of that in more detail, I believe, tomorrow, and what we've learned and found out in our project. But the core consensus, or what was shortened to the C3 project, really lists all of the communication skills and qualifications and outreach skills and some of that. It's a big, thick report, of course. But another major problem that we need to address, and that's one thing we're doing here, is that most of community health worker practice is not within a medical team. They may be hired through a community center out there. They may not even be supervised, but a medical care professional of any kind. And so the NAM report, though, actually alludes to the community health worker being a part of a medical team, which I think most of us feel much more comfortable with. I'm sorry, I'm going. So a couple of resources that are available for all of us that have now come about more recently than what we had when we started our project is the CDC Community Health Worker Toolkit. If you have community health workers in your practice, but you've never really looked at this toolkit, it's probably a wise thing to do because it does lay out a lot of the different pieces of the puzzle that are very helpful, from policy to, it has some wonderful articles in there, et cetera. Also, there was a grant that I bet you some of you are much more aware of than I am, is the our future is there's a project now going on, it's through CDC funding, where it's the community health worker for COVID response in resilient communities. And Virginia has one, it's a contract with CDC, and various states are doing various things with their funding, but the whole idea is to involve the community health worker into the medical team and address the whole COVID issue. So there are some things. So kind of the bottom line of why I'm doing this little intro today is, with our experience and with all the literature that we've looked at, we decided that, gee, we need some kind of framework to put this. And from that, we came up with the 4 categories: the peer community health worker, the general community health worker, the clinical community health worker, and the health navigator. We're going to talk about this in much more detail tomorrow, but we used our literature, we used our experience to really look at where we are and what we've done and where maybe we all ought to look at to see how we can come to, remember I said one of our challenges is that we don't even have correct or standardized language. We don't have standardized training. Having some kind of framework would help us move that needle. This may not be the perfect thing, but we came to these categories with some very hard discussions amongst our team. And we were not all in agreement, but we finally came to this agreement. But we're hoping that the rest of the country will start dialoguing around this, because we think that's the only way we're going to move the needle to move forward. All right, we have some questions, but I'm thinking, shall we entertain questions or keep going? Keep going? I'm getting this. Let's keep going. Which means...
And they're on the screen.
Yeah, and I can't read them. Oh, where's my thing? All right. Oh.
One of them is, what, in your opinion, is the role of payers with regard to the medical home concept? And this is a dual answer, isn't it?
It's a dual. Mm-hmm.
Let's start with the concept itself. Will payers pay for the medical home? Complex question. The payers in general will pay for value, but you have to negotiate that.
Yep.
And the highest level of negotiation is something called the managed care organization. Unless you have a managed care organization, you are not going to be able to do the full Monty medical home concept where you hire all the staff without regard to what it costs, and then you save money that you've been paid up front, and you pocket the difference.
Yep.
Now, that was pretty mercenary and grotesque sounding. But that's what a managed care organization does. And that's not available for sickle cell only providers. Medicaid is the predominant funder of sickle cell care in the United States. Medicaid has many managed care organizations at the level of sections of the state. We negotiate with those organizations. We currently negotiate with those organizations. We have not gotten $1 yet in payment from those managed care organizations for the work that we've done in our medical home. Other states have gotten dollars, but the negotiation happened at the construction of the medical home, as opposed to our case where we had already constructed our medical home, saved money, and then went to the companies and said, hey, we're saving you money. Would you like to share some of your savings with us? And that's the model we're working on. It's a shared savings model with managed care organizations in Virginia. It could go even further to what's called a carve-out. We don't have time to go through all the answers to that. But I'd like you to take the part about paying for community health workers.
I'm torn on that. Because I have a history of being a nurse practitioner, and we didn't get direct reimbursement for many, many, many years, and we had to fight for it. And I'm not sure that was, there's a lot of pros and cons. For the community health worker, I think it's a huge uphill battle. And in discussions with community health workers and the association, they've kind of backed off of asking for direct reimbursement. There's really a movement nationally from there is a Community Health Worker National Association, by the way, and there's groups all around the country, and the ones that I'm listening to, they have conferences, and I don't get to go to them, but when I do look at proceedings, they're kind of backing off of asking for direct reimbursement. They really are moving toward getting to be a part of a medical team and be part of that team that's getting global reimbursement on the value-based payment of care. So if you're out there in a state and you can go find out what's going on in your state and then hop on that bandwagon. But I think that's going to be the way it's going to go.
Interesting.
Yeah.
So I'm going to ask the next question that comes from that.
Ooh.
How will we get standards and certifications and standardized training and licensure? Did I even go that far?
Yeah.
How do we do that?
Yeah. Well, you're part of it right now. Getting the word out. We got to educate our medical care professionals out there. A couple slides back. They don't even know what a community health worker is, much less how we're going to pay for it. So I think we've got to educate. We've got to take action toward coming up with curriculum standards. And there's another group out there that I have to mention is the community college system, which is all over the country. And I think that's another way we can really help get ourselves standardized. And they already have standardized themselves, and they use the term health navigator. That's why we have it on our category 4, because I think we all start needing to be careful about who we're talking about. There's folks out there that use the term patient navigator, and they think it has to be a nurse. Or there might be other places think it has to be a licensed clinical social worker. Well, you know what? We kind of agree that term is out there. But let's put them over there in that category 4. These are folks that have, and here's a major difference between, we're talking about nurses and doctors and social workers. We all go to school first. And we get tested first. We have clinicals. We have to know how to do those things that we come out of school doing. We know how to do histories and all that. We learn that from get-go. And we come out and then we go, oh, I'm here, I get licensed, and then I go get a job. The community health worker is a whole different way of doing it.
It's a different model.
The community health workers go get a job first.
Yeah.
And then expect to get on-the-job training.
Yeah.
And that makes a big difference because, who's going to pay for that if they don't know who this worker bee is and whether they meet certain standards? Okay. So that has got to get decided in the community health world.
I gotcha.
And that's why we came up with our 4 categories, because the 2 in the middle are kind of very overflow, and I think Shirley's going to address this a little more in another day, of how there's a lot of overlap, and we've somehow got to figure out how to set these boundaries and figure out who we're talking about.
Well, that was a very insightful question, and it begged many other questions that we plan to cover. As
we're going to talk
said,
more about this. Yes.
You thought you'd heard The Last of Us, but we're coming back to this. This is a core of what made SCCAPE what it is today. We actually started, and I think that's worth discussing. We started just trying to change the landscape for community health workers.
Yeah.
That was our original sort of core goal. And now look what we've morphed into.
Right.
We're trying to change medical homes.
Yeah.
All right, you get to introduce Shirley.
I get to introduce.